Dr. Al-Awaidi is the former Director of Communicable Diseases Surveillance and Control in Oman. He is currently working as a Communicable Disease Advisor for the Ministry of Health in Oman. Dr. Al-Awaidi has been involved in a number of international committees and works closely with the Eastern Mediterranean Regional Office of the WHO and serves as a member of the IHR Emergency Committee on Polio and the MERS coronavirus. Please, Dr. Al-Awaidi.
Good morning to all. I have the pleasure and privilege of welcoming you to our APACI Respiratory Disease Workshop. We believe it is our duty as associations to continually increase scientific excellence at this meeting or gathering. The MENA ISN stands for Middle East, Eurasia, and Africa Influenza Stakeholders Network. This is a new association that was established sometime in November 2019 with a very clear vision that every country in our region has a realism and implementation of influenza vaccination program and a pandemic influenza preparedness and response plan in place. With informed integration of as much as possible of seasonal influenza vaccine into all our national immunization program as a foundation to minimize as much as possible the health, economic, and social impact of potential influenza pandemic. This workshop undoubtedly plays an important role in mitigating the health and economic and social consequences of possible influenza pandemic. The MENA ISN Association is one of the association also seeks to empower our member states to protect their people from influenza threats. The association is also emphasizes a partnership with many associations to achieve the common goals of influenza, as you see an example of APACI of this partnership. To achieve our goal, this workshop once again look at the most recent global and regional influenza updates, understanding the relevant amendments of the new pneumonia and influenza guidelines as well as their consequences. In addition, you'll be able as much as possible to learn about evolution of vaccines and treatment for influenza, pneumonia, and COVID-19. We hope this workshop will evolve and to become more interactive, enabling every individual or participant to play an active role and enjoy all sections of the workshop. By this, I would like to thank you again for being here and wish you the best and be safe.
Now go through some of the housekeeping issues. So firstly, there will be e-certificates available to all attendees, and they are available in the lobby, but not until tomorrow. From tomorrow, delegates will be able to download those certificates from the lobby area. In addition, there is a feedback form that is available in the lobby area, and I urge all delegates to fill out the evaluation forms before leaving the workshop. So even if you're only here for one day, please complete the evaluation form. It is very important for us to be able to produce better conferences and workshops in the future. Also, delegates can visit the stalls area in the exhibition space This is a wonderful platform, and by visiting that area, you can go in and have a look at some of our sponsors who have kindly provided all kinds of information that may be of use to you. So moving on from that, I would like to now introduce you to the chairman of our first session. The first session for this meeting is on pneumonia. And I'd like to introduce Professor Dr. Shashank Joshi. Professor Dr. Shashank Joshi is an endocrinologist and physician. He's at the Lilavati Hospital and Joshi Clinic. He is a member of the COVID-19 task force for Maharashtra. He has more than 200 orations and awards, and he has more than 800 research papers. So you are in very good hands with the chairman of this next session on pneumonia, Professor Dr. Shashank Joshi.
Thank you very much, the chair, organizers. I would really like to thank you for the opportunity given to me. Let us begin our first session with a poll. You know, this session is on pneumonia, and this session on pneumonia, we have a poll here, and we would like you to take this poll. Have you been vaccinated against pneumonia? The answer is yes or no. We have a mechanism to know the score from Hexicon.
Yes, sir, that will be shown during the discussion time. So
We got it now. We would know how the speakers would perform, but doesn't matter. We will go to the first talk. I saw that some were yes, some were nays, at least in the speaker box. So our first talk is by Dr. Michael Woodward, and he's going to talk on importance of vaccination against pneumococcal disease in older people. Professor Michael Woodward is an associate professor for aged research at Austin Health in Australia. He's a fellow of the Royal Australasian College of Physicians, Australian Association of Gerontology, Australia New Zealand Society of Geriatric Medicines, and the chair of the accreditation committee of the Royal Australian Society for College of Physicians. He's also the deputy and chair of committee for physician training, the body that oversees training of all Australian physicians in internal medicine, and is a member of the Immunization Coalition, which brings together clinicians, members, and chairs of many national and international immunization advisory boards. He's widely lectured on local, national, and international meetings, and he's really going to give us an insight on importance of vaccination against pneumococcal disease in older people, which is his domain, because he's basically a geriatrician. And Dr. Michael Woodward, please.
Good afternoon, Michael Woodward. I'd like to talk about the importance of vaccination against pneumococcal disease in older people. These are my conflicts of interest. I work with a number of companies that make vaccines. I try to be as balanced as I can. Vaccine preventable diseases in older people are important. Older people have a higher incidence of most infectious diseases compared to younger people. They respond less well to treatment. Immunisation against vaccine preventable diseases is as important for older people as for younger people, but vaccination rates are suboptimal in older people. And the immune system, we know, weakens with age, but low baseline immunity does not preclude a robust immune response to vaccination if certain strategies are used, such as adjuvants or higher doses of the antigen. The population health benefits of vaccinating older people with a higher burden of disease but reduced ability to respond to vaccines is greater than the population health benefit of vaccinating younger adults. And some of the factors that limit the success of vaccinations in older adults include a decline in humoral and cellular immunity, a decreased immunological response to vaccines due to immunosenescence, age-related changes in T cell subsets and cytokine production, and also decreased antibody responses to vaccination, leaving older people more vulnerable to infections and to severe complications. Now, if we look at the incidence of community-acquired pneumonia, the topic of this talk, we'll see that it is a disease predominantly of older people. Over the age of 80 in my country, Australia, there's 1,553 cases per 100,000 person years. Lower respiratory tract infection is the fourth leading cause of death in my country, and that's true in most high-income countries, and is responsible for over 4% of total deaths. COVID, of course, might have changed those statistics slightly, but only temporarily. Now, the risk factors for community-acquired pneumonia include older age, chronic comorbidities, as listed there. Importantly, viral respiratory tract infections, especially influenza. Also, impaired airways protection, including macro and micro aspiration. And this is particularly true when people are on proton pump inhibitors, which reduce the normal stomach relative sterility. Smoking and alcohol overuse, as well as opioid use, and other lifestyle factors, including crowded living conditions, which might be relevant in some low-income settings, and also exposure to environmental toxins, possibly also pollution. The national incidence in Australia of hospitalisations for non-invasive pneumococcal disease is bimodal. It's very common for people over the age of 65, the top blue line here, but you'll see that over time it has decreased, particularly since childhood vaccination with the conjugate vaccine. It's relatively stable since around about 2009. Now, pneumococcal infections, of course, can be serious. The infection with Streptococcus pneumoniae, or pneumococcus, is an important cause of pneumococcal disease in adults over 65. The most worrying manifestation is invasive pneumococcal disease, where normally sterile spaces are infected. In adults, pneumonia with bacteremia is the most common manifestation of invasive pneumococcal disease. Pneumococcal pneumonia is a major cause of morbidity and mortality in adults over the age of 65, I beg your pardon. Now, it has decreased. The prevalence of community-acquired pneumonia before 2001 was 26%. Since 2005, it's decreased to 14%. This is community-acquired pneumonia due to pneumococcus. And the reason, again, for that is herd immunity and childhood vaccination. In terms of the burden of morbidity, it mainly comes from invasive pneumococcal disease. Meningitis is a problem. We've actually just in Australia yesterday had a young child die of both meningitis and COVID infection, both present at the same time. But I'm concentrating, of course, on older people. Now, apologies for the slight misformatting of this slide, but what I want to show you is that most pneumococcal pneumonia is non-bacteremic, 80%, with 20% bacteremic. In terms of invasive pneumococcal disease, most of that is indeed bacteremic pneumococcal pneumonia. Some of it is due to meningitis, pleurisy, and arthritis due to streptococcus, but most invasive pneumococcal disease comes from the lung. This is the organism. There's 90 serotypes, 23 of which account for the majority of infections. The fatality rate, if it's invasive, is about 8 to 12%. And the rates of highest disease are in young children and in adults over 65. There's an increasing prevalence also of antibiotic resistance, so we can't rely on those. Resistance to benzoyl penicillin, about 5%, and 20% for some of the other antibiotics listed there. If we look at invasive pneumococcal disease, it's come down dramatically in those over the age of 1 due to childhood vaccination with the conjugate vaccine. It's remained relatively steady for those over 65. That's the orange bar there. Came down a little bit as herd immunity reduced those serotypes in the older age groups. And again, if we look at pneumococcal infections, the notification for invasive pneumococcal disease in Australia is bimodal, affecting young children and progressively older adults. Now, we know that childhood vaccination against pneumococcal disease in my country is very high, using the 13-valent Prevnar 13. In Australia, under the National Immunisation Program, which funds free vaccines, pneumococcal vaccination coverage is still only about 47%, and that's data using the 23-valent polysaccharide vaccine. The burden of morbidity associated with community-acquired pneumonia is considerable. The blue bar here is community-acquired pneumonia, and it's very comparable with respect to, for instance, hospitalisation rates and total cost to some other very common diseases, including myocardial infarction, stroke, and osteoporotic fractures. Indeed, in terms of death, it is much more common cause than these other three diseases. Now, one of the problems with pneumococcal pneumonia infection is it can lead to a rapid or catastrophic cascade of disability. We define this as the loss of independence in more than 3 activities of daily living, and 72% who experience catastrophic disability have been hospitalised. Now, the leading causes of catastrophic disability, which sadly greatly increases the risk of death, are listed here, and you'll see pneumonia and influenza as one of those leading causes. We can avoid this in older people if we use the ways of preventing the disease, and the main way of preventing the disease is vaccination. Influenza is also an important disease, although not so much in the last 2 years, where rates have declined whilst COVID has been causing isolation, masks, etc. Death from influenza is frequently from pneumococcal pneumonia, and the best way to prevent influenza death may be by pneumococcal vaccination. Indeed, it's better to have both. There's 2 studies or 2 vaccines that have been used in older people for influenza to try and overcome immunosenescence. These are the adjuvanted influenza vaccine and the high-dose influenza vaccine. They're more effective than the standard vaccines in older people, but the importance of this slide is to show reduced hospitalisation and death. For instance, if we look at vaccine efficacy against influenza, it's considerable, but if we look at vaccine efficacy against pneumonia, it's even greater. So vaccines against influenza in older people, particularly vaccines that have been modified to combat immunosenescence, can prevent pneumonia and therefore hospitalisation and death. Now, what we see in over 65-year-olds in 2015 and 16 is still suboptimal use of pneumococcal vaccination, 47%. In those over 65, 58% in those over 80, and much lower rates than we're getting with influenza vaccination in my country, where we're regularly getting over 70 to 80% vaccination in people over 70 years old. What's made a difference with both vaccines is making it free. If we look at universal vaccine coverage for influenza vaccination, which was free from 1999, it rose from 61% to 74% in those over the age of 65. If we look at the polysaccharide pneumococcal vaccine, which was free in Australia from 2005, vaccination rates rose from 34% to 56% after it was made free. Now, the adults that are most at risk of pneumococcal disease are, in Australia, those over 65, our Indigenous population, and individuals with comorbidity, which are listed on this slide. If we look at this slide, this is an important, it's somewhat complex, but an important slide that shows the effects of vaccinating children in protecting adults over 65. So this line here is the prevalence of invasive pneumococcal disease due to the 13 serotype, sorry, initially the 7 serotypes in the first conjugate vaccine, which became available in infants in the early 2000s. And we see those 7 serotypes rapidly disappearing in those over 65 as a result of childhood vaccination. Now, vaccination of older people over 65 with the polysaccharide vaccine started in 2005 and possibly also helped because that also includes the 7 serotypes in the conjugate vaccine. One of the resistant serotypes is serotype 3, shown in the triangles here, that hasn't been shifted by any vaccination of children or adults at this stage. When the infant 13 vaccine was introduced, 13-valent vaccine was introduced, we again saw a drop of those serotypes that were in the 13 but not in the 7 in older people. If we look at those that are in the 23 only and not in the 13 or the 7, we've seen a relatively steady amount of those. But if we look at those that are not in any of the vaccines, they're increasing in those over 65, suggesting we're getting serotype substitution. As we eliminate the serotypes in the vaccines, particularly the conjugate vaccines, the other serotypes become more prominent. Now, if we look at this a slightly different way, the years to a 50% reduction in the 7 serotypes or the 13 serotypes in those over 65, it took 2.6 years from the introduction of the 7-valent conjugate in children and 9 years for a 90% reduction when the 7-valent conjugate vaccine was introduced for children. Similarly, again, we're just talking in those over 65, the serotypes that are covered in the 13 but not in the 7, a 50% reduction took 4 years of childhood vaccination and 10 years to get 90% reduction after childhood vaccination. So we see the benefits in older people of childhood vaccination. Now, the key issues that we need to use to work out which vaccine to use in our country for older people are the vaccine type pneumococcal disease in older people. That's pre-vaccination in children. We need to look at the herd immunity from vaccine type disease and from replacement serotypes and how long it could take in our country. We don't know yet the effectiveness, we don't know enough yet about the effectiveness of the polysaccharide vaccine against non-invasive disease in the older people, or indeed the duration of effectiveness of the conjugate vaccine. We do know that the 13-valent conjugate vaccine is effective in preventing those diseases in older people. And we do know that the 23-valent polysaccharide vaccine is effective against invasive pneumococcal disease in older people, and its duration of efficacy is at least 2 to 5 years. We have to consider all these factors when choosing what vaccine is appropriate for our country. Another important factor that's supported the use potentially of the conjugate vaccine in older people is the CAPITA study, where the 13-valent conjugate was used in a very large population, that's Holland, that had not been subjected or exposed to childhood vaccination. There were 40,000 that were given the 13-valent conjugate vaccine and 40,000 plus that were given no vaccination. And it was found that the vaccine efficacy in older people vaccinated with the conjugate vaccine was 75% against invasive pneumococcal disease. It was 42% against all pneumococcal community-acquired pneumonia, but it was not significant against all-cause community-acquired pneumonia. As most systematic reviews of the cost effectiveness of the 23-valent polysaccharide vaccine have shown that it's either cost effective or cost saving in older people. And we can basically summarize this as pneumococcal vaccination with Pneumovax has a vaccine efficacy against pneumococcal community-acquired pneumonia of around 30% and against invasive pneumococcal disease of about 70% in older people. Now, there are other vaccines being developed. Merck has a 15-valent vaccine, which is confusingly given the name V114. This is the current 13-valent conjugate vaccine. This is the 23 serotypes in the polysaccharide vaccine. And Pfizer have a 20-valent vaccine that they're developing as well. So we'll talk about that in just a moment. But essentially, when choosing which vaccine we might use for older people, we need to essentially look at conjugate. This is the 13, but the formula might change with the 15 or the 20-valent versus polysaccharide 23-valent. So in terms of effectiveness against invasive pneumococcal disease, both are very effective. Against community-acquired pneumonia, reasonably effective for the polysaccharide vaccine. Some evidence of efficacy for the conjugate. Interestingly, the effectiveness of the polysaccharide vaccine is greatest in high-income countries. Mortality, probably not much difference. In terms of duration of protection, about 2 to 5 years for both of them. There's much more local adverse effects with the polysaccharide vaccine than with the conjugate. Herd immunity is achieved with the conjugate. And the appearance of replacement serotypes is also seen with the conjugate. So we can summarise those. In support of the conjugate vaccination of older people, we have the problem that replacement strains appear, that it's less likely to be cost effective, and the duration of immunity is suboptimal, but potentially. With the polysaccharide vaccine, we certainly get greater strain coverage, but we have limited effectiveness, particularly against just pneumonia. We have more local adverse reactions. And it can be summarised this way. This was in Lancet Global Health. Whether an argument remains for the introduction of adult conjugate 13 vaccine in view of the expected near elimination of preventable disease from indirect protection, in other words, vaccinating children, should involve clinical decision-making informed by cost-effectiveness assessments that vary between countries and healthcare systems. In America, in 2014, they made the recommendation to sequentially give Prevnar followed by Pneumovax. In 2019, they removed the universal recommendation for Prevnar for several reasons, but one of which is that there was no evidence that the introduction in 2014 of the recommendation to give Prevnar had made any difference. And we can see that in these graphs here. If we look, for instance, just at invasive pneumococcal disease, when Prevnar was introduced in 2014, we saw no reduction in those over 65, or indeed those between 50 and 64, in terms of invasive pneumococcal disease as a result of using the conjugate vaccine in older people. Now, this new vaccine from Merck includes two of the serotypes, 22F and 33F, that account for about 10% of all invasive pneumococcal disease in a number of countries across the world. So it should theoretically be advantageous. Also, it includes the serotype 3, which is the first or second most important contributor to invasive pneumococcal disease, again, across a range of countries. And I'll come to the effectiveness of that in just a moment. This was the study. It was a 30-day immunogenicity study carried out in these countries, seen down the bottom. And here's the important data. It showed non-inferiority, in fact, possibly even slight superiority of the vaccine against some of the serotypes. Certainly, though, the non-inferiority margin was not crossed, so it was as good as the previous conjugate vaccines. But here's a very important point. If you look at serotype 3, it was 60% more effective. So that's really, I think, very important compared to PCV 13. It was 60% more effective in terms of immunogenicity. Now, just to talk about revaccination, there is evidence that revaccination is as effective as primary vaccination with the polysaccharide vaccine. Immunity probably lasts for about 10 years. Previously, I said 5 years, but there's data to support longer coverage. And in fact, because revaccination has the same initial boost in immunity, and so this is the blue line, initial boost in immunity and then sustained immunity out to 5 years at least, there is evidence to support the revaccination of older people with the polysaccharide vaccine 5 to 10 years after the initial dose. And that's the recommendation of the Society, the Australian and New Zealand Society for Geriatric Medicine, that I've written the immunisation guidelines for. Now, in terms of vaccinating with both influenza and pneumococcal vaccination, there's two meta-analyses that have done. I'll just look at the Zhang one here, which showed that dual vaccination was associated with significantly lower pneumonia than influenza vaccination alone, and a significantly lower all-cause mortality than influenza vaccination alone. So there's good evidence to support the use of both influenza and pneumococcal vaccination at the same time. And the biggest thing that will impact upon implementation is recommendation from a doctor. For instance, if we look at pneumococcal vaccination, a patient is 32 times more likely to accept the doctor's recommendation and be vaccinated against pneumococcal disease than if no such recommendation is given from their doctor. And the same is true to a lesser degree with flu and shingles vaccination. So in summary, community-acquired pneumonia is a common and significant cause of morbidity and mortality in the older population. Improving both influenza and pneumococcal vaccination will further reduce this burden of disease. And a medical recommendation to get the influenza and pneumococcal pneumonia vaccine is one of the strongest influences on a patient's vaccination behaviour. And I would also recommend that you lead by example. If you're over 50 or particularly over 65, as a physician, you should also be receiving both pneumococcal and influenza vaccination. Thank you very much for listening. End of talk.
Thank you so much. We will, if there are any questions for Dr. Michael, we could take them now because it is quite late in Australia now. So if there are none, let us move to the next speaker. Next speaker is Professor DJ Christopher. He's a professor of pulmonary medicine from the Christian Medical College, Vellore. He's a past president of the Indian Chest Society and the Indian Association of Respiratory Care, and a former chair of the Indo-US Report TB Consortium. He's a Grand Challenge awardee, and he has several other publications, including 190 peer-reviewed publications and 14 book chapters. Dr. DJ Christopher is going to talk to us bacterial pneumonia, the changing spectrum of the disease in India. Professor Christopher.
Thank you, Dr. Sashank. I am indeed pleased to be in this meeting and in the midst of very eminent speakers. So my task is cut out. I have to talk about bacterial pneumonia, this changing spectrum in India. So we all know that there are 2 million deaths in all ages due to lower respiratory infection. And it particularly takes a toll in sub-Saharan Africa, Southeast Asia, and South Asia. 197.05 million episodes of pneumococcal pneumonia were reported worldwide. And it is a leading cause of lower respiratory tract infection, morbidity, and mortality. And as it turns out, between 2005 and 2015, globally, there has not been much of a change in lower respiratory tract infections, although the age standardized death rates fell by 19.5%. This is the global burden of disease data. It's only in the last few years that we have some authentic data of what could be the situation in India. So the estimated number of pneumonia and severe pneumonia among children under 5 has decreased between 2000 and 2015, and that's good news. It is attributed to improvements in socioeconomic indicators, government initiatives, and furthermore, the pneumonia incident rate still remains high. And so the publication recommends that new vaccines targeting pneumonia pathogens should be inducted into the country. So this is the data for the respective states. And as you can see, the high prevalence states with these reddish kind of spectrum of colors are the northern Indian states. And the ones with intermediate prevalence are parts of middle India, and then essentially low prevalence is reported in southern India, northeastern India, and Jammu and Kashmir. So India contributes to about 23% of the global pneumonia burden and 36% of the WHO regional burden under 5 years. Reliable estimates of disease burden are not available for the adult population. And all that we are going to see in the next few minutes is from sparse data available mostly from tertiary care centers and with usually cross-sectional study designs. So this is an article that has collated a lot of information that's available in the literature, and it reiterates the role of strep pneumoniae as a etiologic factor in community-acquired pneumonia. Emerging pathogens like Burkholderia pseudomyeli are increasingly being recognized. There are 4 million deaths across the region, as I alluded to in the previous slide. The case fatality rate across various studies is between 2 to 20%, increases to up to 50% in those admitted to intensive care units. And the fatality depends on the different settings, healthcare settings, geographic regions, patient categories, and age. And across these variables, the spectrum of variation is extremely wide. More data on mortality. Mortality rates are less than 1.5% in outpatient settings and as high as 12% in hospitalized patients. In a study of 150 patients hospitalized with CAP, 8% patients died in the hospital, 2.5% succumbed 30 days within 30 days of discharge. Among hospitalized patients, the incidence of bacteremic pneumonia was 25% with a mortality of 20%. The incidence of infection peaked in winter as well as the spring. Looking at data on strep pneumonia, I see a lot of discussion will hover around strep pneumonia. Nevertheless, I'll quickly glean through this information. These are the studies that reported the prevalence of pneumonia in India, the etiologic factors encountered in CAP. And strep pneumonia has been reported in as high as 55% in this study to as low as 3.8% in this study in Srinagar. So essentially, there is wide variation in the role of strep pneumonia in CAP. Having said that, everybody agrees that it is probably the commonest pathogen and perhaps the most important. According to REACH, a multinational study, 35 to 36% of patients with CAP did not have microbiologic diagnosis, resulting in empiric antibacterial therapy. Diagnostic testing in patients with suspected pneumonia is driven mostly by the care facility. And of course, disease severity, access to healthcare, and availability of clinically useful tests. So by clinical microbiologic diagnosis is quite challenging. And sputum happens to be a key sample in CAP. And the utility of sputum, again, there are challenges. This is a study from Brazil. 78.8% of patients of CAP presented with expectoration. Only 33.6% of them were subjected to bacteriological tests. Despite productive cough, 45% were unable to produce a sample for testing, or the physician failed to order the test. 3.5% were satisfactory for analysis, and etiological agents were detected in only 28.2% of these samples. So when we talk about microbes in CAP, we have a lot of challenges in what we have to deal with to establish microbiologic diagnosis, and not to mention the data that we have on the etiology. I'm going to look at ANSOP study group, which reported the epidemiology and clinical outcomes of community-acquired pneumonia in adults in Asian countries. It is a prospective study, and this probably is the most comprehensive study of the bacterial pathogens in community-acquired pneumonia. So this study covered 1,031 cases from 14 centers early in this millennium, 2002 to 2004, and 955 filled diagnostic criteria. The highest numbers from Korea, 35.4, followed by Hong Kong, China, India, and so on. Microbiologic etiology could be determined in 428, which is 44.8% of the patients, which was definitive in 52.1% of cases and presumptive in 47.9%. Overall, a total of 390 bacterial pathogens were isolated from 349 patients, a yield of 36.5%. And of 349 patients with bacterial pathogens isolated, mixed infections were found in 60 patients, 17.2%. And they were as follows: 44 had 2 pathogens, 8 had 3, and again 8 more had 4 pathogens. These are the etiologic factors in the order of prevalence. Strep pneumoniae 29.2, Klebsiella 15.4, Haemophilus 15.1, Pseudomonas 6.7, Staph 4.9, and Mycobacterium tuberculosis 3.3. So in India and perhaps in other Southeast Asian countries, Mycobacterium tuberculosis is a pathogen that we cannot ignore even in the context of CAP. These are the mixed infections. The combinations were strep pneumoniae, chlamydia 15%, strep pneumoniae mycoplasma 8.3%, strep pneumoniae Klebsiella 8.3%, strep pneumoniae catarrhalis 6.7%, and again H influenza with Klebsiella, with catarrhalis, with chlamydia, and with other pathogens. This is the antimicrobial susceptibility of the major pathogens. Strep pneumonia. Now the sensitivity to penicillins was only 47.4%. It was much better with co-amoxiclav, 86%, and not so good with erythromycin, and not so good with cephalosporins, but with levofloxacin and vancomycin, they were excellent. And H. influenzae, again, excellent results with co-amoxiclav, and also equally good results with most of the important antibiotics. Klebsiella, modest response, 75% with co-amoxiclav, in improving with cephalosporins, and again ciprofloxacin and imipenem gave the highest susceptibility. According to the IDSA and ATS guidelines, macrolides, doxycycline, or fluoroquinolones are recommended as monotherapy for OPD CAP. However, in Asian countries, they may not be appropriate as monotherapy, since resistance to these are very prevalent. Also, single use of lactam agents would result in clinical failure if CAP is caused by multiple agents, including atypicals. So this particular study concluded that regardless of microorganisms, risk factors, and severity of CAP, a combination regimen, especially third generation cephalosporin and macrolides, would probably be the combination of choice for patients. The study reported 30-day mortality, which was 7.3% overall. I looked carefully at the pathogens. None of them actually had significant odds. Strep pneumonia 1.7, atypical pneumonia 0.54, and combination therapy with antibiotics 1.29, but the p-values of none of these were significant in the univariate analysis. However, multivariate analysis again showed several important risk factors: mechanical ventilation, nursing home residents, respiratory rate more than 30, hyponatremia, malignancy, and cardiovascular disorders. However, the pathogens themselves did not seem to have a clear, show a clear risk factor or risk feature towards 30-day mortality. Before closing, I just briefly want to glean through the India Cleanse study, which looked at invasive pneumococcal disease, which the study reported had high case fatality rate in India. This study was done from my center for over 15 years, concluded in 2008, was a seroepidemiological and antimicrobial resistance of invasive pneumococcal disease in hospitalized patients of 7 tertiary care hospitals in India of 449 adults. And this is the spectrum of clinical presentation, meningitis being the highest invasive pneumococcal disease with strep pneumonia, followed by sepsis and followed by invasive pneumonia. So with that, I conclude. Lower respiratory tract infection and pneumonia are leading cause of morbidity and mortality globally. India contributes about 23% of global pneumonia burden and 36% of WHO regional burden of inpatients under 5 years. Reliable estimates of disease burden are not available, particularly for the adult population. But the data available suggests that emerging pathogens like Burkholderia pseudomallei are being increasingly recognized. Asian data suggests the need for combination antibiotic therapy, regardless of microorganisms, risk factors, and severity of CAP. Thank you very much.
Thank you so much, Professor Christopher, for your nice talk. And we'll have the panel discussion at the end of all the 3 talks. So let us move on to the next speaker, Dr. Rajadhar. We know Dr. Rajadhar is the director and head of pulmonology department at the CK group of hospitals in Calcutta, director research and education at the National Allergy and Asthma Bronchitis Foundation Institute, and chair of various educational initiatives in the Indian Chest Society. He is an examiner for MRCP in UK and India, and is abstract reviewer for the American College of Chest Physicians, American Thoracic Society meeting, and European Respiratory Society. Dr. Rajadhar is going to discuss the need for pneumococcal vaccine in India, what is different in the guidelines, and then we'll have a question and answer session.
Hello, friends. It gives me great pleasure to welcome all of you to this APACI meeting. A warm welcome to all my colleagues from India and outside who are listening in to us today. I'm here to talk to you about pneumococcal vaccination in India and what's different in the guidelines. I would think that what I'm going to say is important, is relevant to a lot of people in developing countries, even outside India. We will have a special focus on areas where we are different to the existing ACIP guidelines, and I'll try and take you through why we are different. So this is what is on the anvil, the global perspective and how the ACIP guidelines have changed. We will talk about our vaccination guidelines in pneumonia, and I'll tell you why I'm calling it our guidelines. We'll talk about the ICS NCCP guidelines and the important differences between the ACIP guidelines and the Indian guidelines. So when you look at global vaccination recommendations in chronic lung disease, the ones that I will quote briefly here are the ACIP 2019 guidance. This is a little different from the 2015 guidance, and I'll tell you how it's different. There's the Spanish Consensus Scientific Society guidance, which is a bit dated, about 7 years now. That's from 2014. And then there's a brief mention about vaccination on our Bible, the Gold Guidelines for COPD from 2019. So this is looking at the 2015 ACIP guidance. And you can see that in people who are pneumococcal vaccine naive above the age of 65, the recommendation at the time was PCV 13. followed more than a year later by PPSV23. And in persons who had previously received PPSV23 at age of greater than 65 years, it was PCV13 after more than a year. And in patients who had received PPSV23 before the age of 65 and who are now aged greater than 65, it was PCV13 when the individual, not the patient, was above 65 years old, and then again a PPSV23 1 year after. I want you to hold that thought because I'll tell you now how things have changed according to the 2019 guidance. This is the ACIP adult immunization schedule, and I want you to see where my cursor is. This says pneumococcal conjugate vaccine, which is the PCV13, and it then says pneumococcal polysaccharide vaccine, which is the PPSV23 vaccine. So here we talk about up to the age of 64, we talk about both vaccines. But at the bridge, so cusp between 64 years and 65 years, we still talk about PCV13, followed by PPSV23. And after that, we are talking just about PPSV23. So that's what the guidance shows from 2019. After the age of 65, ACIP now says that PCV13 administration should be based on shared clinical decision-making between the individual, that's the adult above age of 65, and the doctor, unless these patients have an immunocompromising condition or a CSF leak or a cochlear implant, and those who have not received PCV13 in the past. So in other words, people who have not received PCV13, has a cochlear implant, has a CSF leak, has an immunocompromising condition, will definitely have PCV13. For the remaining population, you have shared decision-making between the patient and the doctor. If the decision to administer PCV13 is made, it should be administered first, followed by PPSV23. There's no confusion in this. It's always been like this, and we'll tell you how and why that is in a minute. The recommended interval between the two pneumonia vaccines remains the same, and all adults who are aged more than 65 years should definitely receive a PPSV23. So this is the updated guidance. Patients above the age of 65 who have not had PCV13 in the past should be offered a PCV13, especially when they're residing in nursing homes or other long care health facilities. People who are residing in settings with low pediatric PCV13 uptake, and this is important again, because this includes India, and we'll come back to this. Persons traveling to settings with no pediatric PCV13 program, and patients aged more than 65 with comorbidities, and you can see the various comorbidities on there: the chronic heart disease, lung disease, liver disease, diabetes, alcohol, and smokers have been classified as the chronic diseases or comorbidities, as we term them. This is the Spanish consensus statement from 2014. It's a long document, but to cut a long story short, the 16 signatories of this consensus scientific society considered that adults with underlying conditions should be vaccinated against pneumococcus and preferably receive at least one dose of PCV13 to be administered before PPSV23 in those cases where revaccination is indicated. So much more broad-based, but on similar lines as to what ACIP recommended. So this is again the Spanish consensus statement. I want you to look at the bits which are in red. Those are the ones which are worth remembering and maybe slightly different to what you saw with ACIP. So here the recommendation is to give PCV13 followed by PPSV23. The minimum interval between the two vaccines is 8 weeks. 8 weeks. Remember that it's 8 weeks, especially if the patients have immunocompromising conditions, chemotherapy, myeloma, chronic kidney disease, Hodgkin's lymphoma, etc. The interval should be short. If there is no immunocompromise, you tend towards a year, but the gap should be between 8 weeks to 1 year. And in the list of chronic diseases, you can see smoking and interstitial lung disease making an appearance. These I think are important. And we've included this in our guidance, which I'll speak to you about in a minute. The gold guidance from 2019, this is the gold guidance from 2019, which was published in 2020. And it says pneumococcal vaccination for all patients above 65, also recommended in younger COPD patients with comorbidities. PCV13 has been shown to exhibit at least the same or greater immunogenicity with PPSV23 up to 2 years after vaccination. And in a large RCT, PCV13 demonstrated significant efficacy for prevention of vaccine-type community-acquired pneumonia and vaccine-type invasive pneumococcal disease above the age of 65. And here, the efficacy persisted for more than 4 years. So again, the guidance is of very similar ilk. Gold, because of the nature of the document, it's a COPD document, has not gone into great details about the vaccination process. Let's now turn closer to home. This is the Indian vaccination recommendations in chronic lung disease. There's actually many more than the ones I have listed, but the ones I've listed are the more recent ones, and I think the ones which are relevant to our discussion today. So the Physician Society, the Geriatric Society, the Indian Academy of Allergy, the Indian Medical Association, and last but not the least, our society, our guidance, which is the most recent guidance from India, the Indian Chest Society and National College of Chest Physicians guidelines from 2020. This is the adult immunization from 2000, schedule from 2014. This is from the API. And this says the available evidence at that point in 2014 recommends widespread use of PPSV23 among adults with chronic lung disease. Paradoxical lack of benefit in the high-risk group, which is the chronic disease group, is low control event rates in included trials, poor immunogenicity in patients with chronic disease, and low sensitivity of diagnostic criteria. The reason I show you this guidance is not for us to follow this, but to say that things have changed in this time, and there's valuable evidence available today, which has led to this change. The 2014 guidance also talks about PCV13, the fact that it should be offered to eligible adult patients greater than or equal to 18 years, following a discussion on the currently available evidence. The European agency has approved the use in adults above 18 years of age, and the need for revaccination with the subsequent dose of PCV13 has not been established. So that's nothing changed from 2014 in 2021. A repeat dose of PCV13 is still not required even today. This is the Geriatric Society of India guidance, and this again says more of what's the recent evidence, PCV13 first, followed by PPSV23. It talks about the time interval of 1 year, similar to what ACIP did. And if adults above 65 years receive PPSV23, then he'll receive PCV13 after 1 year as per their previous recommendation. The IMA, again, I'm not going to read through this. The only important part here, again, similar to our guideline, which I'm going to describe soon, is the fact that it's 50 years rather than 65 years. PCV13 recommended for adults over 50 years, and PPSV23 recommended for high-risk population, that's children above 2 years and adults. And in immunocompromised individuals across different age groups. So these are people with immunocompromised, people who are going to mass gatherings, and I want you to hold this thought too, because we'll come back to this when we talk about the Indian Chest Society guidance. So vaccination recommendation for Hajj pilgrims. This is both for pneumonia and influenza, and then other chronic lung diseases, other end organ damage, diabetes, etc. So that's not just immunocompromise, but comorbidities. And I want you to remember the travel bit, which is pertinent in India, but also in lots of countries. So this brings me finally to our guideline, the guideline which was established as a joint initiative of the Indian Chest Society and National College of Chest Physicians. This was a meeting that was held in Kolkata with 24 experts and 4 moderators and 4 rapporteurs. The expert panel contained not just pulmonologists, but other specialists like nephrologists, diabetologists, immunologists from all parts of India. We tried to ensure that there was equal representation from the length and breadth of the country. And we reviewed the existing literature, which include randomized clinical trials, systematic review, meta-analysis, and the other guidelines, which I've quoted here, but even outside the ambit of what was there in this talk. We formulated questions following discussion, especially questions which were important in an Indian context. Literature review and discussions of diseases were coordinated by group chairs and were well documented by the rapporteurs. Discussion regarding the grading of evidence was held independently in 4 parallel groups and thereafter in joint sessions, including all the experts. We had a modified grade system. Evidence was defined as being grade 1, grade 2, and grade 3. And then expert opinion was defined as usual practice points. The strength of evidence was then graded as A or B based on the level of evidence. So A is a recommendation, a positive recommendation, and B is just suggested. So that's the table. This wouldn't be new to you. This grading system has been used across the board in lots of guidelines and statements, and hence I'm not reading you through this particular slide. So pneumococcal vaccination in case of adults are recommendations between 19 to 65. So pneumococcal vaccination not recommended for healthy adults under the age of 65. So no comorbidities, non-smoker, you wouldn't recommend vaccination. The next grade is patients who are between 19 to 65, but immunocompetent with comorbidities. And you can see the list on there, not different to what we've had before. You can see the current smoker and alcohol abuse, which we have taken from the guidance that we spoke about a little while ago. A single dose of PCV13 followed by PPSV23. And the window we have chosen, similar to the Spanish guidance, is more than 8 weeks and less than 1 year. And then the last category, which is patients with a past history of invasive pneumococcal disease, the cochlear implant patients, the CSF leak patients, and those with impaired splenic function. This again is a single dose of PCV13 followed by PPSV23 8 weeks or more later. In all immunocompromised individuals now, and you can see the immunocompromised list, not different to the list of immunocompromised I spoke about a little while ago, a single dose of PCV13 followed by PPSV23 recommended. So remember the kidney disease, the hematological malignancy, the transplant patients, HIV, all are present in this category. How is it different to the ACIP guidance and why is it different? So this we have alluded to before, but let's sort of discuss this in slightly greater detail now. The reason the ACIP guidance changed in 2019 was the fact that since 2010, the US has been vaccinating all its children with PCV13. Hence, by 2019, when they came out with this guidance, most of the adults had been vaccinated with PCV13, and hence they had herd immunity. For us, pediatric immunization schedule is only about 3 years old, and that too, it's not compulsory, and very little population has been covered. Hence, the concept of herd immunity is not yet applicable in an Indian scenario. And I emphasize on the word yet because it's a part of the guidance now. And once it becomes more widespread, more children get vaccinated, we will also go the US way in developing herd immunity. Hence, when we developed the guidance in 2019, 2020, the bottom line was that vaccination with PCV13 should be followed by PPSV23. And like we said, in the future, when we have herd immunity due to vaccination of children with PCV13, we will revisit the guidance like ACIP did and hopefully make the change where post 65 years, administration of PCV13 would not be compulsory. Above the age of 65, that's the next category. We recommend vaccination with PPSV23 as a compulsory move. So all above 65-year-olds should be vaccinated with PPSV23 because of the higher incidence of invasive pneumococcal disease in this population. The individuals that have immunocompromising condition, anatomic asplenia, cochlear implant, CSF leak, invasive pneumococcal disease, it's again, like before, PCV13 followed by PPSV23. And the patients with chronic comorbidities, not dissimilar to the previous group, chronic heart disease, liver disease, diabetes, lung disease, smokers, the decision is to administer a dose of PCV13 preceding PPSV23, and the decision should be jointly taken by the physician and the patient. So we recommend vaccination with PPSV23 in all adults above 65 and repeat vaccination. And remember, this is important. The repeat vaccination with PPSV23 causes hyporesponsiveness, and hence this should be solely based on clinical judgment. No routine revaccination after 5 years, as was recommended in some of the previous guidelines. The dose and route of administration is a no-brainer. You all know this. These are drugs for IM vaccine administration. The contraindications are not many, and I won't dwell on this. So hypersensitivity to vaccine component is the only known definite precautionary contraindication to administration of vaccine. They should not be given during acute respiratory illness. So someone febrile, someone coughing, wheezing should not be given the vaccine. In case of pregnancy, PCV13 is not recommended. And even the use of PPSV23 during pregnancy is not got a specific recommendation due to lack of adequate safety data. Co-administration, so these two vaccines, the PCV13 and PPSV23, there's no question of co-administration because we've said the vaccines should not be given within 8 weeks. However, in theory, there's no contraindication of giving them together. What is the pneumococcal vaccination recommendation if the individual has received PPSV23 first? Here we have not differed in any way to ACIP. For individuals who've received PPSV23 initially and where PCV13 is indicated, a single dose of PCV13 should be administered more than 1 year following the receipt of PPSV23. What about co-administration of two pneumococcal vaccines? We've said this already. Why PCV13 before PPSV23? And again, this you all know. The fact that both vaccines elicit a B-cell mediated response. However, PCV13 has a T-cell dependent immune response. The T cells are important for the development of immunological memory and gives you long-term memory. And hence it's essential for the maturation of the B-cell response. Hence PCV13 first, followed by PPSV23. So in conclusion, I think we need greater awareness and we need to have a noise about these new guidelines, specifically for India. But like I said, I think these guidelines are important, they're relevant for a lot of countries throughout the world. Like all other vaccinations in adults, we should join hand and spread the word for pneumococcal vaccination. And we should do that in conjunction with influenza vaccination. With COVID, this is the window of opportunity. People are vaccine conscious. They want to take vaccine. And this is the window of opportunity we should use to try and ensure that both adult respiratory vaccines, pneumonia and influenza, are popularized throughout the world, especially the developing world. Thank you very much for listening. And I hope all of you have a great conference.
Thank you so much, Dr. Raja. So we can have a quick discussion. Thank you, Dr. Michael, for staying up for us, and Dr. Christopher and Dr. Raja. Hopefully, I joined. We are, I think, learning. We are going before schedule, and we had some very elegant talks which were there. So let me start with Dr. Michael Woodward. What would be your? This is the opinion poll which was taken in. Have you been vaccinated against pneumonia? Around 37% probably said yes, and a reasonable percentage which remained said no. So that was the opinion poll. So let me go to our Australian speaker. What is his opinion? Can we have the slide off, please? Professor Michael, what are your thoughts on Raja's comments and recommendations he has given? And then we'll come to Dr. Christopher. And my second suggestion is that in Australia, not elderly, but in the younger population, what is the standard of care in pneumococcal vaccines?
Yeah, thank you very much. Look, basically, I agree. I think that when we have herd immunity with the conjugate vaccine in children, we don't need to use the conjugate vaccine in older people. But when we don't yet have that, the conjugate vaccine followed by the pneumococcal polysaccharide vaccine is the way to go. I can't speak about childhood vaccination because I'm a geriatrician, but I know it's a very good uptake in older people. I think the recommendation that only the conjugate vaccine be given to older people makes no sense if you have herd immunity due to childhood vaccination. The serotypes just aren't there. So I would always recommend that the polysaccharide vaccine be the preferred vaccine when there's strong vaccination of younger people with the conjugate vaccine. Having said that, if you are going to use the conjugate vaccine, you should always use it and then follow it up with the polysaccharide vaccine, the Pneumovax 23, because that covers many, many more serotypes. The only serotype that is problematic is serotype 3. And as I said in my talk, I think some of the new vaccines, the new conjugate vaccines, such as the Merck one and possibly the Pfizer one, seem to actually have a good efficacy against the serotype 3. So maybe we will still recommend the conjugate vaccine just to cover serotype 3 in all age groups.
Michael, one other question which is not related to this is we are in COVID times. Do you think any of the conjugate vaccines will have an indirect impact on the innate and cellular immunity, which may impact COVID outcomes?
Yeah, that's a very good question. I'm not sure about the answer to that. I certainly know that we don't want to give too many vaccines that, if you like, stress the immune system. However, there is good evidence that you can give a number of vaccines at the one time. For instance, the conjugate vaccine with the shingles vaccine can be given. So I don't know the answer to that question. I certainly wouldn't want to in any way compromise the use or the effectiveness of the COVID vaccine by other vaccines. I think the first priority is the COVID vaccine, particularly in these times.
Thank you. Thank you, Michael, so much. So let us go to Dr. Christopher. Dr. Christopher, you presented a lot of data, Asian data, global data, and Indian data. Do you think that the adult data in this space is sufficient enough for us to recommend a recommendation which Dr. Rajadhar was making? Or do you still feel that we need more data, more evidence, and this is just a vaccine company thing? Are you convinced beyond reasonable doubt, or you still have doubts?
Well, I'm not sure if I can directly link my information with what Dr. Rajadhar said, but I can say for sure that this was a challenging topic. I had to sift through so many studies to get patchy information. And so I can say confidently that with regard to microbes for CAP, and in fact, even lower respiratory infections in general, the data from India is extremely sparse. Now, that's the reason why I briefly gleaned the IndiaClin data, which was actually one of the substantially well-planned study over a long time, prospectively looking at patients with invasive pneumococcal disease. So that, to me, was the only well-planned, methodically collected data. So I think, I really think that to make big conclusions, we need better data.
At CMC Vellore, do you use a pneumococcal vaccine in adults in routine care, and what are your indications? What is the CMC plan for it?
Yeah, so I can, well, in CMC, in several departments, they do give adult vaccination. In my department, perhaps we give more vaccines than anybody else, and perhaps many adult departments put together. So the commonest scenario is for patients with chronic lung disease. Obviously, in a respiratory department, that's what you would expect. So COPD patients, bronchiectasis patients, and those with immunosuppression coming to us with lung infections, and even asthma. So these are the populations that and interstitial lung disease now we are seeing in much larger numbers than before. So these are the target populations that benefit from vaccinations.
Thank you. Thank you so much. Anyone, Dr. Rashid, you wanted to ask a question, Dr. Sala? Anyone has any comments or questions? I saw something in the chat blocks. I don't see Dr. Rajadhar here. I don't think he has joined. Somebody's asked a question that, somebody has talked about the cost of the vaccine. Dr. Christopher, would you like to take a call on this? The PCV23 is an expensive vaccine, and so between the conjugate and the polysaccharide, do you have a choice?
So it is true that the conjugate vaccine is significantly more expensive. It could be twice as expensive as the polysaccharide vaccine. That is true. So in terms of, being pragmatic, if a patient cannot afford a more expensive vaccine, we give the polysaccharide vaccine. If patients can afford both vaccines, we give them the conjugate vaccine followed by the polysaccharide vaccine in that sequence. So that is our protocol. But cost, this is all out of pocket expenses, and so we have to be very conscious of costs in India.
I think Dr. Harunor has a
yes.
question.
Yeah, actually, this is to any of Dr. Christopher or Michael. I mean, the question here is that we are very likely to get a conjugate vaccine, 23-valent conjugate vaccine in the next, I don't know, years, 7-8 years time. So what may happen at that time? Looks like that we are preferring at this moment 23-valent conjugate, polysaccharide vaccine. So if we get instead a conjugate vaccine for elderly, what should we do at that time? And certainly it would be very expensive, I guess. Thank you.
Michael,
I can thank you. I can say something about that. I mean, the problem is that the more serotypes you put on a conjugate vaccine, theoretically, the less immunogenic they are. You can't have, for instance, a 93-valent conjugate vaccine, which might cover all of the common serotypes that give you a pneumococcal disease, but they would not be sufficiently immunogenic. I think 20 is probably as far as you can go, and that still has problems. I'm surprised, to be honest, that the Merck proposed vaccine, which is a 15 conjugate, is actually so effective against serotype 3. There must be some other explanation for that, and I haven't fathomed that. Yes, but you're right. If we had an effective 23-valent conjugate vaccine, it would always be preferable to the 23-valent polysaccharide vaccine. But I don't think that will be true. I don't think it will cover the serotypes as well. So that's my thoughts.
Dr. Michael, there is another question from Dr. Tejal. This is in the geriatric immunology space. Why is aging with immunosenescence not considered as an immunocompromised state?
So immunosenescence refers to the inability to mount an immune response against a disease, and also the ability to mount a antibody response with a vaccine. And I think basically that's quite different to immunocompromising, where a vaccine could potentially cause an unwanted response, such as with the live virus vaccine, such as the Zoster vaccine. So immunocompromised people should not ever be treated with an with a live vaccine, a live virus vaccine. And they're also, it is true, less likely to mount an immune response. But immunosenescence refers more to the inability to mount a response with a vaccine. That's why with immunosenescence, we need to enhance our vaccines. And as I said in my talk, there are many ways to enhance the immunogenicity of a vaccine to overcome immunosenescence, and they include high dose of the antigen or an adjuvant.
Thank you. So she's asked one more question, Michael, too. So if a 65-year-old patient has received PCV13, and then after 1 year gets PPSV23, do they still need a booster of PPSV 23 after 5 years?
Certainly the guidelines for the Australian and New Zealand Geriatric Society that I have produced would do state that we should be given a second dose of the polysaccharide vaccine after 6 years. And as I showed in one of my slides, the immunogenicity, the antibody response, if you like, the protectiveness of the polysaccharide vaccine does actually reduce after about 5 years. Some would even state giving a second booster vaccine, and some would even state giving a booster every 5 to 10 years indefinitely, although that's not necessarily cost effective. So yes, even if they've had the conjugate vaccine, if they do have an indication for then giving the polysaccharide vaccine, I think it's quite appropriate to give a second dose, in other words, their third pneumococcal vaccine after 5 to 10 years.
Dr. Christopher, any comments would you like to make?
I think I agree with that.
There are no more questions. Anybody else wants to ask a question here? I don't see any other questions from the team here. So I must thank Dr. Michael Woodward for an outstanding talk. And thank you so much for staying up. I know it's very late there and we have distressed your sleep today. So sleep well. And thank you so much. And Dr. Christopher, as usual, unusual, thank you for your wonderful talk. Dr. Raja, we have to thank him virtually. Probably he's too busy giving another talk. And thank you all the organizers for this wonderful symposium. And let's hope that we will have a safer environment and we'll move out from a virtual space to a physical space as we move on with COVID in times to come. Thank you.
Thank you.